In this video, we are going to learn about schizophrenia and other related disorders. Let's start learning. It is the German psychiatrist Emil N., who is best known for his careful description of what we now regard as schizophrenia. The risk of developing schizophrenia over the course of one's lifetime is little under 1%, actually around 0.7%. What this means is that approximately 1 out of every 140 people alive today who survive until at least age 55 will develop the disorder. Of course, a statistic like this does not mean that everyone has exactly the same risk. This is an average lifetime risk estimate. As we shall see later, some people's for those who have a parent with schizophrenia have a statistically higher risk of developing the disorder than do others, people who came from families where there has never been a case of schizophrenia. There are also other groups of people who seem to have an especially high risk of developing schizophrenia. For example, people whose fathers were older, 50 years or more at the time their birth have been recorded, and they elevated the risk of developing schizophrenia when they grew up. Having a parent who works as a dry cleaner is also a risk factor. Rates of schizophrenia are also higher than expected in first and second generation immigrants, particularly those from Black Caribbean and Black African countries who live in minority white communities. Although the reason for their differences are not well understood, they are of great interest in researchers. The vast majority of cases of schizophrenia begin in late adolescence and early adulthood, with 18 to 30 years of age being the peak time for the onset of illness. And although schizophrenia is sometimes found in children, such cases are rare. Schizophrenia can also have its initial onset in middle age or later, but again it is not typical. The characteristic age of onset of schizophrenia differs in men and women. In men, there is a peak in new cases of schizophrenia between ages 20 and 24. The incidence of schizophrenia in women peaks during the same age period, but the peak is less marked than it is for men. After about age 35, the number of men developing schizophrenia falls markedly, whereas the number of women developing schizophrenia does not. Instead, there is a second rise in new cases that begin around age 40, as well as third spike in onset that occurs when women are in their early 60s. In addition to being more likely to have an early age of onset, males also tend to have a more severe form of schizophrenia. Brain imaging studies show that schizophrenia-related anomalies of brain structure are more severe in male patients than they are in female patients. Gender-related differences in illness severity may also explain why schizophrenia is more common in males than it is in females. The male-to-female ratio is 1:4:1, so for every 3 men who develop the disorder, only 2 women do so. If women have a less severe form of schizophrenia, and if they also have more symptoms of depression, they may either not be diagnosed at all or else be diagnosed with other disorders, thus giving rise to the sex ratio imbalance. That's another possibility. First, criteria. 2 or more of the following, each present for a significant portion of time during a 1 month period, like successfully treated. At least one of these must be present as a symptom, like delusions, hallucinations, disorganized speech, like frequent incoherence, and grossly disorganized or difficult behavior, negative symptoms like diminished emotional experience or expression. For a second portion of the time, For a significant portion of the time since the onset of the disturbance, level of functioning in one or more major areas such as work, interpersonal relations, or self-care is markedly below the level achieved prior to the onset of when the onset is in childhood or adolescence. There is a failure to achieve expected level of interpersonal, academic, or occupational functioning. Continuous signs of disturbance persistent for at least 6 months. 6 months period must include at least 1 month of symptoms or less if successfully treated that meet criteria A. Active phase symptoms and may include periods of prodromal and residual symptoms. During this process, the signs of the disturbance may be overcome by negative symptoms. Then the disturbance is not attributable to the physiological effects of substance. And next, some other topics are also dealt with there. Not all people who have delusions suffer from schizophrenia. However, delusions are common in schizophrenia, occurring in more than 90% of patients at some time during their illness. In schizophrenia, certain types of delusions or false beliefs are quite characteristic. Prominent among these are beliefs that one's thoughts, feelings, or actions are being controlled by external agents, made feelings or impulses, and one's private thoughts are being broadcast indiscriminately to others. Thought broadcasting, and thoughts are being inserted into one's brain by some external agency, like thought insertion, and in some external agency has robbed one of one's thoughts through withdrawal. And also common are delusions of reference, where some neutral environmental events such as television program or song on the radio is believed to have special and personal meaning intended only for that person. Other strange propositions, including delusions of body change, bowels do not work, or removal of organs, are also not uncommon. Then positive symptoms are those that reflect an excess or distortion in a normal repertoire of behavior and experience, such as delusions and hallucinations. Disorganized thinking, as revealed by disorganized speech, is also thought of it this way. Negative symptoms, by contrast, reflect on the absence or deficit of behaviors that are normally present. Current thinking is that negative symptoms fall into two broad domains. One domain involves reduced expression behavior, either in voice, facial expression, gestures, or speech. This may also show itself in the form of blunted affect or flat affect, or an allogia, which means very little speech. The other domain concerns reductions in motivation or the experience of pleasure. The inability to initiate or persist a goal-directed activity is called avolition. For example, the patient may sit for long periods of time staring into space or watching TV with little interest in any outside work or social activities. Diminished ability to experience pleasure is called anhedonia. Although most patients exhibit both positive and negative symptoms during the course of this disorder, the presence of negative symptoms as the clinical picture is not a good sign for the patient's future outcome. Even though patients with negative symptoms may have emotionally unexpressive, how they appear and how they are feeling are two different things. In an important early study studied by some scientists, mediated male patients with schizophrenia while they were watching film clips. The different types of film clips were used, the scenes in them being very positive, very negative, and neutral in terms of the emotions. They were designed to elicit in the viewers videotapes of how the patients looked while they were watching the film were then coded by trained raters, and as they are expected, the patients with schizophrenia showed less facial expressiveness than a group of healthy controls. What was surprising was that when the patients were asked about their emotional experience about the films, they reported as many emotional feelings and sometimes slightly more. Measures of autonomic arousal also showed that when they were watching the films, the patients exhibited more physiological reactivity than the controls did. Although the original research used only male patients, a recent study that includes women with schizophrenia has replicated the results about diminished emotional expression. What the findings suggest, therefore, is that even though patients with schizophrenia may sometimes appear emotionally inexpensive, they nonetheless experiencing plenty of emotion. Then there are some subtypes of schizophrenia. There is a great deal of heterogeneity in the presentation of schizophrenia, and patients with this disorder often look quite different clinically. In consideration of this, the DSM IVTR recognized several subtypes of schizophrenia. The most clinically meaningful of these were paranoid schizophrenia, where the clinical picture is diminished by absurd and illogical beliefs that are often highly elaborated and organized into a coherent through delusional framework. Then disorganized schizophrenia, characterized by disorganized speech, disorganized behavior, and flat or inappropriate affect, and catatonic schizophrenia, which involves produced motor signs that reflect great excitements to stupor. Unfortunately, results using the subtype following did not yield much insights into the etiology or treatment of the disorder. Reflecting this, subtypes of schizophrenia are no longer included. What might explain the better clinical outcome of women with schizophrenia and possibility that women sex hormones play some protective role? Female hormones play some protective role. When estrogen levels are low, as into as is true premenstrually, and are falling, psychotic symptoms in women with schizophrenia often got worse. The protective effect of estrogen may therefore help explain both the delayed onset of schizophrenia and the more favorable clinical courses of disorder in females. Declining levels of estrogen around menopause might also explain why late onset schizophrenia are much more likely to strike women than men. There is some evidence that this late onset pattern in women is associated with the more severe clinical presentation. Then clinical picture, identify the symptoms of schizophrenia. As we have mentioned earlier, the DSM is a work in progress. Diagnostic criteria are not fixed and instead change subtly over time as new research findings become available. Then delusions will be there. A delusion is essentially a erroneous belief that is fixed and firmly held despite clear contradictory evidence. The word delusion comes from the Latin word ludere, which means to play. In essence, tricks are played on the mind. People with delusions believe things that others who share their social, religious, and cultural backgrounds do not believe. A delusion therefore involves a disturbance in the content of thoughts. Not all people who have delusions suffer from schizophrenia. Schizophrenia occurs in people from all cultures and from all walks of life. The disorder is characterized by an array of diverse symptoms, including extreme oddities in perception, thinking, action, sense of self, and manner of relating to others. However, the hallmarks of schizophrenia is a significant loss of contact with society, referred to as psychosis. Although the clinical presentation of schizophrenia differs from one patient to another, the case of Emilio is quite typical. Then origins of schizophrenia construct. The first detailed clinical description of what we recognized into schizophrenia was offered in 1810 with Haslam, the apothecary of the Bethlehem Hospital, London, England. Haslam described the case of patients who appear to have suffered from a variety of symptoms, including delusions that are typical of schizophrenia. 50 years later, the Belgian psychiatrist Benedict Morel described the case of a 13-year-old boy who had formerly been on the most pupil in his school, but who gradually lost interest in his studies, became increasingly withdrawn, reclusive, and quiet, and appeared to have forgotten everything he had learned. Morel thought the boy's reluctant moral and physical functions had deteriorated by a result of pain regeneration of hereditary origins. It is used the term demence, or I'm sorry how to pronounce this, mental deterioration at an early stage to describe the condition, is also distinguished from the dementing disorders associated with old age. Next symptom, disorganized speech. Delusions reflect a disorder of thought, and next disorganized speech will be there. Then disorganized behavior. Some negative symptoms are there. Along with that, some other psychotic disorders are also associated with that, like schizoaffective disorder, schizophreniform disorder, then delusional disorder. Then some genetic and biological factors are also related to that, like genetic factors are there. Then urban living, immigration, other approaches. Then genetic factors, stress, psychosis, developmental maturation process, prenatal and perinatal events, all this lead to brain vulnerability. Then pregnancy and birth complications, early nutritional deficiency. Then some other disease called attenuated psychosis syndrome, structural and functional brain abnormalities. Then brain development in adolescence, brain functioning related things, how to do individual treatment, psychosocial approaches. Prenatal exposures and neurodevelopmental perspectives also very important. Then do bad families cause schizophrenia? Parents are not responsible for this. Then psychosocial and cultural factors. Then diathesis stress model of schizophrenia. Neurocognition and associated stuff. Schizophrenia is an immigrant from China. Then cannabis use and abuse, neurochemistry, brief psychotic disorder, then 4 days of symptoms and rapid recovery, and what the world around us says about this. Then adoption studies related to this. Then social cognition, pharmacological approaches. The loss of brain volume, affected brain areas related to that, treatments and outcomes. Clinical outcome is there, mortality rate are associated with this. Then urban living, how urban living and immigration influences genes and environment in schizophrenia. Then families and relapse. These are the main topics related to this major topic of schizophrenia. When we try to have a quick recap of this topic, schizophrenia is a serious mental disorder in which people interpret reality abnormally. Schizophrenia may result in some combinations of hallucinations, delusions, and extremely disordered thinking and behavior that impairs daily functioning and can be disabling. People with schizophrenia require lifelong treatment. Early treatment may also help get symptoms under control before serious complications develop and may help improve the long term outlook. Then, schizophrenia symptoms involve a range of problems with thinking, cognition, behavior, and emotions. Signs and symptoms may vary, but usually involve delusions, hallucinations, or disorganized speech and reflect an impaired ability to function. Symptoms may include delusions. These are false beliefs that are not based on reality. For example, you think that you are being harmed or harassed. Certain gestures or comments are directed at you. You have exceptional ability or fame. Another person is in love with you, or a major catastrophe is about to occur. Delusions occur in most people with schizophrenia. Then hallucinations. This usually involves seeing or hearing things that doesn't exist yet. For the person with schizophrenia, they have the full force and impact of a normal experience. Hallucinations can be in any of these senses, but hearing voices is the most common hallucination. Then disorganized thinking or speech. Disorganized thinking is inferred from disorganized speech. Effective communication can be impaired, and answers to questions may be partially or completely unrelated. Layered speech may include putting together meaningless words that can't be understood, sometimes known as word salad. Then extremely disorganized or abnormal motor behavior. This may show in a number of ways, from childlike silliness to unpredictable agitation. Behaviors isn't focused on a goal, so it's hard to do tasks. Behavior can include resistance to instructions, inappropriate or bizarre posture, a complete lack of response, or useless and excessive movement. Then negative symptoms associated with this refers to reduced or lack of ability to function normally. For example, a person may neglect personal hygiene or appear to lack emotion, doesn't make eye contact, doesn't change facial expressions or speak in a monotone. Also, the person may lose interest in everyday activities, socially withdraw, or lack the ability to experience pleasure. Symptoms can vary in type and severity over time, with periods of worsening and remission of symptoms. Some symptoms may always be present. In men, schizophrenia symptoms typically start in the early to mid 20s. In women, symptoms typically begin in the late 20s. It's uncommon for children to be diagnosed with schizophrenia, are rare for those older than age 45. Then symptoms in teenagers. Schizophrenia symptoms in teenagers are similar to those in adults, but the conditions may be more difficult to recognize. This may be in part because some of the early symptoms of schizophrenia in teenagers are common for typical development during teen years, such as withdrawal from friends and family, a drop of performance at school, trouble sleeping, irritability or a depressed mood, then lack of motivation. Also, recreational substance use such as marijuana, LSD, or methama, methamphetamines or LSD can sometimes cause similar signs and symptoms. Compared with schizophrenia symptoms in adults, teens may be less likely to have delusions, more likely to have visual hallucinations, and when to see a doctor. People with schizophrenia often lack awareness that their difficulties stem from a mental disorder that require medical attention. So it often falls to family or friends to get them help. Helping someone who may have schizophrenia. If you think someone you know may have symptoms of schizophrenia, talk to them about your concerns. Although you can't force someone to seek professional help, you can offer encouragement and support and help your loved one find a qualified doctor or mental health professional. If your loved one poses a danger to self or others, or it can't provide his or her own food, clothing, or shelter, you may need to call 911 or other emergency responders for help so that your loved one can be evaluated by a mental health professional. In some cases, emergency hospitalization may be needed. Laws on involuntary commitment for mental health treatment vary by state. You can contact community mental health agencies or police departments in your area for details. Then, suicidal thoughts and behavior. Suicidal thoughts and behavior are common among people with schizophrenia. If you have a loved one who is in danger of attempting suicide or has made a suicide attempt, make sure someone stays with that person. Local emergency number, use that number, or if you think you can do so safely, take the person to the nearest hospital emergency room. What are the causes? It's not known what causes schizophrenia, but researchers believe that a combination of genetics, Brain chemistry and environment contribute to development of the disorder. Problems with certain naturally occurring brain chemicals, including neurotransmitters called dopamine and glutamate, may contribute to schizophrenia. Neuroimaging studies show differences in the brain structure and central nervous system of people with schizophrenia. While researchers aren't certain about the significance of these changes, they indicate that schizophrenia is a brain disease. Then risk factors, although the precise case of cause of schizophrenia is unknown, certain factors seems to increase the risk of developing or triggering schizophrenia, including having a family history of schizophrenia, some pregnancy with birth complications such as malnutrition, or exposure to toxins or viruses that may impact brain development. Then taking mind altering drugs or psychoactive or psychotropic drugs during teen years and young adulthood. Some complications: left untreated, schizophrenia can result in severe problems that affect every area of life. Complications that schizophrenia may cause or may be associated with include suicide, suicidal attempt, and thoughts of suicide, some anxiety disorders, and obsessive compulsive disorder OCD, then depression, abuse of alcohol or other drugs, including nicotine, inability to work or attend school, financial problems and homelessness, social isolation, health and medical problems, being victimized, aggressive behavior, although it's uncommon. Then prevention. There is no sure way to prevent schizophrenia, but sticking with the treatment plan can help prevent relapse or worsening of symptoms. In addition, researchers hope that more training learning more about risk factors of schizophrenia may lead to earlier diagnosis and treatment. Thank you for listening.